Good morning, everyone. We are working on getting the video capture set up, so bear with us for the next few minutes, but I will make a couple of announcements and then introduce our speaker for today. So I'm Kira Larson, if I haven't met you before. I work in the Stanford Center for Clinical Research. I'm the Education Program Manager. We host these Science Series lectures every month. If you aren't on my listserv, let me know at the end of class or send me an email and I'll add you. Because we do these every month, and next month on August 17th, we're hosting an organ procurement coordinator. She's non-Stanford external coming in to talk to us about the organ procurement process. So I think that'll be really interesting, and I hope you guys will come to that. Same system for signing up. I'll send out a flyer, and there'll be a Qualtrics questionnaire to fill out in order to register. For other classes that are coming up, the week of August 15th is going to be really busy for me. I shouldn't have done that way, but it'll be back-to-back classes. So August 15th is one of the elective courses for the certification program, and I will be doing that along with Haley Headland, who is PhD in biostatistics, and she's going to be presenting research study designs, and I'll be talking about phases of research. It's a 1-hour course, an elective through Spectrum, and it's on August 15th from 9 to 10. And then on August 16th is the next informed consent class, which I'm also doing. So if you haven't come to that yet, that's also another class that's done monthly, and you guys can sign up for that. It's through the Spectrum certification program, and it's a 2-hour class from 9 to 11 on the 16th. Anyone have any questions about any of that, about the certification program? And almost all of the classes that I host within SCCR, you can use as an elective course for the Spectrum certification program. So just keep track of the classes that you go to. You don't have to tell Spectrum that you attended them, but just keep track of them, and once you reach all your requirements for the program, you can kind of turn in your sheet. There is a sign-in sheet, so please sign in. And I will send the evaluation probably by the end of the day today. So I appreciate the feedback. It's really helpful. If you do want BRN credits for this class, please fill out your name and BRN number on the evaluation. Otherwise, I won't know who you are because it's anonymous. So just fill that out for your credits, and then I will submit that and get that certificate to you. Yeah. It's circulating, I think. Yeah. It's going around. Are we still not ready to go? Okay. So this is obviously an older room, but they put in new equipment for video capture, and this is one of the classes that I really want to capture, so hopefully we can get that up and running. In the meantime, we'll go ahead and get started. I'll introduce our speaker for today. So Poonam Hosamani obtained her Doctor of Medicine from the Feinberg School of Medicine at Northwestern University in 2009, and her BA in Biological Sciences also from Northwestern. She completed her residency in internal medicine at New York Presbyterian Hospital at the Cornell Medical Center. She's currently working in the Division of Hospital Medicine and is serving as the co-director of transition to clerkships for second-year medical students, preparing them for their upcoming clerkships. She was recently presented with a Clinical Educator Award from the Society of General Internal Medicine. So thank you to her for doing this. We're really excited to have her. I think this is one of those topics that we all see in research, and it'll be a really good, interesting class for today. Does anybody have any questions before we get started? Awesome. You can go ahead and maybe just kind of start off, and we can wait for him.
No problem. Thank you so much, Kara. I really appreciate the invitation, and thank you to all of you for being here this morning. I really hope to make this a really fun, interactive session, kind of like the physical exam is anyway. Really, it's not taught best in a lecture format, but I would really love for this to be as interactive as possible. If you have questions at any point along the way, please feel free to stop me, to interrupt me. If you want me to demonstrate any parts of the physical exam, that wasn't something we had initially planned for, but I'm always happy to show you guys kind of what things are, if there's particular physical exam maneuvers that you have questions about or that you've heard about, or if you have physical ailments that you want diagnosed. I'm always happy to lend a little bit of my, my expertise in that. So demystifying the physical exam, I think it's one of those things that can seem very nebulous. When you go to see a doctor, when you're reading, reports of a physical exam, it can often be very confusing to understand why is it that they're doing these parts, what does all of this mean? And so our goal today is really to help you understand a little bit of that. And again, any other questions that you might have, I'm always happy to answer. I love this, I think it's so funny. But the physical exam is really such an essential part of what we do as physicians for a number of reasons. And so it's something that I, as a medical educator, help to teach from the very beginning stages of medical school and as we train people who are going into clinical medicine because it's such a vital skill to have. So who am I? So Kara told you a little bit about my educational background, but just a little bit about what I do here at Stanford. So I'm a hospitalist in internal medicine, which basically means that my clinical practice is solely within the hospital. I only see patients who have been admitted to Stanford Hospital. I don't have a clinic where I see patients on an outpatient basis. My clinical practice is solely there. So I end up seeing a very high acuity group of patients who are quite sick, sometimes who need ICU level care, things of that sort. So that's where my clinical practice is based. What I do in my non-clinical time is mostly medical education. So I have a number of roles within the medical school as well as within the internal medicine residency program. And then I'm a member of the group in bedside medicine, which is led by Dr. Abraham Verghese. Some of you may know he's one of our crown jewels of Stanford, illustrious clinician as well as author. And he created something called the Stanford 25, which I will, there's links to the Stanford 25 website later on in my presentation. But basically the idea of bringing medicine clinicians back to the patient's bedside. There's this whole movement, I think, in general in medicine to, with technology and things like that, where clinicians are moving further and further away from actually being with our patients. And his dream was to really try to reverse that trend. And so some of what we do is different initiatives within Stanford as well as nationally and internationally to try to promote the idea of bedside medicine, clinical skills, physical exam skills. And so the picture here is actually from our annual Bedside Medicine Symposium, which is taking place later this summer in September. If any of you are interested, I'm happy to provide that information, but it's a 3-day long seminar where we go through all kinds of exam skills. We have people who come from all over the world actually to try to learn physical exam skills from Dr. Verghese and from our group, so it's a really exciting thing to be a part of. In addition to all those things, I'm also a mom to some fur babies as well as a real baby. So this is kind of just rounds me out as a person. These are my dogs Juno and Ziggy, and then my daughter Manvi. So there's a lot of fun. In case you guys were wondering, I have actually done physical exams on all 3 of these individuals at various points in time. I've diagnosed Juno with conjunctivitis. I think Ziggy had a few ticks that I had to remove because my husband is not medical, and so I've had to do a couple things with that. And then Manvi as well has had a number of different ailments that I've had to do pediatric exams for, which I'm not great at, but I'm working on. So I'd love to know a little bit about all of you and your background. So I know that all of you are part of the Center of Clinical Research. Are there people who have clinical training backgrounds who have gotten physical exam training? Oh, wonderful. Perfect. Oh, wonderful. Great. So this will be probably all stuff that you already know. Feel free to chime in if there's anything that you see. Oh, wonderful. Welcome. Perfect. So you're actually doing physical exams, which is great. Are you doing like pretty comprehensive exams, or are they focused on one particular body system? Got it. Great. Great. Is anyone else actually performing parts of the physical exam? Like whether it's vital signs or anything like that? And then sometimes here and there, are people doing mostly, are there other people doing like chart reviews and things of that sort? I sort of geared my presentation more for that, for people who are doing chart reviews to understand what it is that we document when we do the physical exam. But certainly for those of you who are doing pieces of the physical exam, if there are things you have question about technique and all that, I'm happy to answer those questions. Oh, wonderful. Oh, great. Well, I'm sure you could probably teach me a couple things. Well, great. And is there anyone else that had any particular things that they wanted me to cover? We have plenty of time for questions at the end, but if there was anything that anyone had burning questions about. All right. So what are we trying to accomplish today? So discussing the role of the physical exam in patient assessment, figuring out who can actually do a physical exam. Short answer is anyone can do one, but there's some kind of more finer points about, from a medical legal perspective, what that means. Understanding components of the physical exam, differentiating normal versus abnormal physical exams, translating the terminology. Honestly, this is the hardest part of it, is understanding what the heck we're talking about when we document parts of the physical exam, and then, of course, any questions that people have. So components of a patient visit. So the big thing to think about is if you're doing a chart review, you're looking at a patient encounter, differentiating first the setting of it, so inpatient versus outpatient. But beyond that, patient visits are actually pretty much the same. There's a few things that basically have to be in documentation. The first part is a history of present illness, or a subjective portion, so that's what the patient actually tells you or what information that you gather from them, why they're visiting your office or why they're in the hospital in my particular case. Then there's an objective data gathering component of a patient visit. So this can be vital signs, usually a physical exam, which we'll talk about today. And then kind of beyond the scope of today, but other objective data gathering pieces would be labs and radiology, whether it's ordering those labs if you're in the outpatient setting, or reviewing the results of those labs, which is typically what happens in the inpatient setting. And then an assessment and plan. What do you think is happening with this patient? And then what is your plan going forward? Are you starting any new medications? Are you sending them to a particular test? Are you sending them for a biopsy, et cetera, et cetera? So those components are really what goes into it. There's not a lot more beyond that. So I think it's nice just to understand a little bit about when you're looking at a note, you can look for all of those things and make sure that you have all those components. So what is the purpose? Why is it that we do the physical exam? That's actually a very hot question these days. Unfortunately, like I kind of mentioned, the physical exam is under a lot of scrutiny because we have so much wonderful technology to show us what's going on with patients, that there's this movement to say, well, what we're doing at the bedside with patients really that relevant? And I would argue that it really is. One is that it gives us clinical context. I'll go into a little more detail about that. We're able to create differential diagnoses based on the exam and patient symptoms. It helps build rapport, and I don't think that can be emphasized enough. Like, there's really a lot that goes into that touch component when you're examining a patient that goes a long way to building that physician-patient relationship, provider-patient relationship. And then billing, unfortunately, things do come down to money. So the physical exam actually is a key component of that. So the clinical context, a lot of this makes sense, right? You have someone who comes in and says, I have pain in my foot. If you don't look at their foot, there's not really a lot that you can do. So that's how we decide what parts of the physical exam that we want to do. I think a lot of us are used to when we go to see a doctor, for like an annual exam, they do more of a head to toe kind of thing. If people come in with specific complaints, we decide based on what they tell us, what kind of parts of the physical exam would be most relevant. And that differs for every clinical situation, every patient. For something like shortness of breath, when I hear shortness of breath, that immediately lights up a number of different things, and so helps me guide my exam and say, well, shortness of breath, most often probably caused by something within the lungs and the heart more often, so I'm going to focus my physical exam on those parts of the body. Weakness in my arm, obviously you want to look at the arm itself, but then also focus on something like the neurologic exam and looking at the spine to look at, is there something within the spine that's causing weakness? Do they have a pinched nerve, something of that sort? And then the differential diagnosis. This is something, again, that a lot of providers just learn how to do. When you hear a complaint, when you see something in a patient, you immediately come up with a very broad range of things that this could be. For example, chest pain has a number of different things that could be causing it. And then what we do progressively is, as we do the physical exam, as we gather data, that narrows down more and more into eventually what we hope to get is a diagnosis. So building rapport, this is such a key part, and a lot of what Dr. Abraham Verghese actually talks about and writes about. If you haven't read any of his work or seen any of his articles, he talks about something called the I patient, which is basically this idea that patients exist within like Epic or within a medical record, and that's all we know about them. And his kind of challenge to people is to say, why can't we go and talk to that person and learn their story, and see who they are, and bring them from the EMR into real life, and really trying to harness the importance of that physician-patient or provider-patient relationship. So that's a lot of what we focus on, is learning how to do the physical exam to try to build that rapport, recognizing that that relationship is an important part of the healing process, important part of the treatment process. I think for a patient, it's probably very hard to understand or to want to accept treatment from someone who you don't trust, who you don't feel like has your best interest at heart, who doesn't know you from your I patient identity. And so that's really why a lot of us in the bedside medicine group take this charge so seriously, because we want to make sure that we're training the next generation of providers to understand the importance of it, and that no matter how great our technology is, there's nothing that can really replace that connection that you have with a patient who's there in the moment. So from a billing perspective, this is kind of where we're getting down into the nitty-gritty. So obviously it's wonderful to try to do the physical exam, but there are certain guidelines that we have to follow in terms of billing from CMS, from the Center of Medicaid and Medicare Services. So this is just a very quick summary from their website, basically of how it is that we determine, based on the physical exam that we do, how we're able to bill for those services. So you can do a problem-focused exam, which is very limited. So if, for example, someone comes in with foot pain, you examine the foot, that's a problem-focused exam. Going all the way down to a comprehensive exam, someone who's maybe very ill, or someone who's coming in for an annual physical, and where you do more of a head-to-toe exam, and so you would bill differently for that, for doing that part of the exam, as opposed to more of a problem-focused. Just in case anyone was wondering or is doing any research and looking at billing codes and things like that, this is basically just a breakdown of like the code that's used, and then the number of body parts. They actually do break it down into like the body parts or body systems that are that need to be documented. And so oftentimes when you see a physical exam in an Epic or an EMR, it's not written in like paragraph form. It's actually broken down into the body systems, and that's really so that our billing provider, our billing people can then count the number of body systems that are documented, so it's much easier to be able to bill more accurately, as opposed to like if you're just like writing and waxing poetically about someone's physical exam. So that's often why you see that documented in that way. That's often one of those things when we are teaching medical students, when they first write notes, they don't look at notes beforehand to know what it's like. So they often write in paragraphs, and we have to do a lot of training to be like, no, you actually do have to kind of bullet point it and clarify the body system that you're examining. So who can perform an exam? Anyone can obviously do a physical exam. Everyone is capable. I would encourage people to do physical exams if you haven't done that, because I think that there's something very special about it. I think it builds a lot of perspective that you don't necessarily get when you don't have that patient contact. For billing purposes, though, specifically, this is a little more specific. So physicians, and that includes residents and fellows, so an attending physician can bill for a physical exam that was done by a resident or fellow, but not by a medical student. Nurse practitioners and physician assistants can perform exams that can be billed from. CRNAs and CNSs can as well. So there's just very specific guidelines. It's basically just for my purposes as a hospitalist, I can't bill from a medical student physical exam, but I could from a resident. Are there any questions about this? I know this was a particular question that came up. Yeah. That they can, I don't know if there's like a certification necessarily, if it's for research purposes, because I don't think it's being billed for, from my understanding. So I think you can certainly do a physical exam. It's just a matter of whether it's or not you can actually bill for that particular service. Because it doesn't necessarily require a certification to say you've passed and now you can do a physical exam on someone.
Can I just
oh yeah.
About that? So the other thing, and I know this might sound kind of silly to say, but if you're a coordinator and you don't have any clinical experience, there are certain things you can be trained on that from a documentation standpoint or diagnosing someone that's something that's not something coordinators. So I know that's kind of silly to say out loud, but I just wanted to clarify, make sure that everybody's on the same page with that. Okay.
And certainly we always recommend people to suggest if they see something, if you happen to be doing a physical exam and you see something, tell someone, if you are working with someone who has a medical background or things like that, and be like, hey, can you come look at this? I noticed something, just love to get your opinion. We actually do that all the time in the hospital, so it comes up quite a bit. So this is the rest of what we'll really talk about is what makes up a physical exam, and then as well really decoding all the language that we use, because I know that's really the toughest part of it. So what's normal and abnormal? So there's a really wide variation of what's considered normal, and it really depends on the clinical scenario. And abnormal, just because something is abnormal doesn't necessarily mean that it's actually clinically relevant. So case in point, does anyone know what this deformity is that's in the picture? It's pretty striking. I kind of heard. Pectus excavatum, yeah. So this is a congenital deformity of the chest wall that basically causes this sinking in appearance of the sternum, and usually actually doesn't have a lot of clinical relevance. So it looks severe, but patients don't actually typically report a lot of symptoms. Sometimes people can have some limitations in breathing occasionally, depending on how severe the deformity is. But for the most part, it's something that we just note on our physical exam as being present, but not necessarily of having any sort of clinical significance. So vital signs, this is something that's part of every physical exam. It's really encouraged to do. This one is one that can be performed by a nurse, a nurse's assistant or medical assistant. I heard that there were some people who maybe were doing parts of the physical exam, maybe vital signs as part of a research purpose when you're intaking a patient who's coming in for research purposes. It's not always labeled, the different parts of the vital signs, so this is why it's important just to know some of the things that are talked about. So T obviously stands for temperature, BP, blood pressure, heart rate or pulse, same thing, basically, but this refers to your heart rate. The RR is your respiratory rate, and SpO2 stands for the oxygen saturation. A quick note about respiratory rate. If any of you are doing chart reviews on patients who are in the hospital, the respiratory rate is notoriously wrong. Everyone automatically just puts in 20, but an actual respiratory rate of 20 is actually pretty abnormal, but everyone just automatically puts it in. So again, it's sort of clinical context. When you see something higher than that, that's when you get concerned. If you see something in the single digits, that's also of concern. But there's a very wide range of what's acceptable in between. And oftentimes people don't spend the time to sit there and count someone's respirations for an entire minute, because that can be really taxing and really boring. Any questions about vital signs? So ins and outs, are there people who are doing chart reviews on hospitalized patients? See a few nods. So this is something that'll come up particularly in someone who has been hospitalized. This basically stands for intake and output. It's really a measurement that's done within the hospital to measure what someone is taking in by mouth and then what they're outputting both by bowel movements as well as urine output. So it's often reported as a net value over 24 hours. So when you see a value in there, it'll say, negative 2.5 liters. That means that their net intake was negative 2.5 liters over the past 24 hours. There's often places in Epic that you can look into to actually, it'll show you by shift, by nursing shift, how much the intake and output was for each shift. But then usually when it's reported in a note, like a progress note, it comes up looking like a net value. So just, something to keep in mind. Again, the measurements of this, you would think would be like very precise. They're not. So unfortunately, when you're measuring intake, obviously this includes solids as well as liquids. So it's often an estimation by a nurse or a nurse's assistant as to how much someone is taking in. The output as well. We try to be as accurate as we can. The only way to be completely accurate is if someone has an indwelling catheter that's measuring their urine output. Oftentimes, though, otherwise, it's just an estimation. We have patients, urinate into like a hat in the toilet and try to measure that way, but inevitably, there's it's not completely accurate. So take it with a grain of salt, but it hopefully gives you an overall assessment of how much someone's taking in, how much output that they have. But if you are using this as part of your research protocol, if this is something that you're really looking at, I would take a deeper dive into seeing how the measurements were made. Does this person have an indwelling catheter that's measuring their urine output, or is this more just an estimation that the nursing staff is using? So there's often a general part of the physical exam, which is when, basically when you walk into the room, what does this person look like? A well-appearing AAF and NAD, ANO times 4, you're like, what does that even mean? Basically, when you translate that out into plain English, it means African-American female in no apparent distress, who is alert and oriented to person, place, time, and situation. That's really what that translates out to. You'll often see that ANO times 3 or times 4 basically just tells you, they've asked the question, do you know your name? Do you know where you are? Do you know what year it is, what date it is? And then, why are you here, basically? We see patients on a very wide spectrum of that within the hospital, I'm sure in the outpatient setting as well. So an abnormal general would be something like a young female who's somnolent, not easily arousable, alert and oriented times 1 to person. This is an example of something that you might see written about someone. This is someone who sounds like they're probably pretty sick, someone typically who I would see in the hospital setting. But again, just an example of what's more of an abnormal general part of the exam. So body systems. The remainder of the exam is split up into different body systems, like I said, more for billing purposes, but also just to keep us organized. The placement of parts of the physical exam may vary by provider. So for example, if a patient has a rash on their leg, some people might include that in the skin exam portion. Some people might include that in the extremity portion. The actual placement of it doesn't really matter, but just to note that there are variations is important. Most of the exams actually in Epic are actually templated to normal. So you'll often see, if you're doing a lot of chart review, you'll probably see that all the exams look very strikingly similar, the same language is used. That's because there's these templates that exist. And then providers will then go in and add in abnormal findings as they come up in the exam. So just to be aware that there unfortunately is a lot of that templatedness that is there. So it's good to know just what the normal template looks like so that you can actually tell if someone's taken the time to go in and add stuff. Most parts of the exam consist of an inspection portion, a palpation portion, potentially a percussion portion, and then an auscultation portion, special maneuvers. Do people know what I mean when I say percussion? Is that something that people are familiar with as a technique? That's something that we do. Yeah, I see someone kind of making a motion. So this is something that we do for part of the lung exam in particular, and as well as the abdominal exam. It's basically looking for differences in resonance that happen. So actually all of you can do this right now just at your table. If you take this knuckle here, the upper knuckle of your middle finger, and then take another finger and tap on your table. You can actually kind of demonstrate. You can hear that sound that you make. And then if you do it on different surfaces, you'll hear different sounds. It's kind of like a fun party trick that you can do. So this is something that we do for patients in different parts. We can compare if they have fluid in one area or air or things of that sort, and try to sort things out that way. But that's really what we mean by percussion. It's a skill that takes a while to really perfect, but one that we think is really important and actually has a lot of clinical significance. So HENT, does anyone know what this stands for? Perfect. Some people are kind of right. So head, eyes, ears, nose, and throat. So it's typically what most exams will start with. Can anyone translate this part for me? This is a very, very common notation that you'll see for a normal HENT exam. I would love to have someone raise their hand and see if they can translate all that terminology for me. And I believe you guys had, if I remember, there were some people who were at the medical terminology lecture a couple months ago. Any guesses on what NCAT means? So it refers to the head. Normocephalic. AT is hard. It's atraumatic. Yeah, so normocephalic, atraumatic. How about perla? Yeah, so pupils equal, round, and reactive to light. And the A, accommodation. So you'll often see either PERRL, pearl, or perla, as part of it, depending on what parts of the exam that they did. EOMI. Exactly. Yeah. So extraocular movements intact. So this is where we'll have patients kind of we'll make an H symbol with our fingers and test the different muscles of the eye to see whether all those movements are intact. And the OP stands for oropharynx is clear. So again, this is what you would translate this out to into. Oh, sorry, I forgot. MMM is moist mucous membranes. So this is what a normal HEENT exam would look like. So an abnormal exam, I just did this as kind of a, the description doesn't necessarily match the picture. The picture is just in there to demonstrate the finding. But someone who had an abnormal exam might comment on the pupil sizes being different, one not being reactive to light and being fixed. They have an erythematous pharynx with exudates noted on bilateral tonsils. But that's just an example of what you would comment on in an abnormal exam. This obviously, just looking at this poor girl, you can tell that this does not look good to have such an abnormal difference in the size of her pupil. So this would obviously be someone to be very concerned about. So the neck exam, does anyone know what this physical exam finding is? Yeah, so this is thyromegaly. So this is some kind of increase in size of the thyroid gland. So a normal neck exam would look something like this. You would comment on whether the neck was supple or not, whether you're able to move it around, whether there's any JVD. Notice if people know what JVD is? Jugular venous distension. So obviously our colleagues who work in the cardiology department would know about this a lot. This basically tells us whether patients have increased amounts of fluid on board, whether there's a challenge with them being able to pump blood through their hearts. Is it backing up into their neck veins where we can actually see it? Cervical LAD. What is LAD? Lymphadenopathy. And then carotid bruits would be if you listen with a stethoscope over the carotid arteries. Normally you shouldn't hear anything. If there's a sound, that basically means that there's some degree of narrowing of that carotid artery, which you'd be concerned about. And then thyromegaly, we talked about. So a normal cardiovascular exam might look something like this. So I'd love to have people talk us through. What is RRR? Regular rate and rhythm, perfect. S1 and S2 are just the heart sounds, the lub-dub that you would typically hear about. RMG. We love to abbreviate everything. It's really ridiculous after a certain point. So, sorry? Yes, it's actually rubs, murmurs, and gallops. The PMI is a point of maximal impulse. This is something where we can actually feel the heart beating. Usually on the left side of the chest, there's a small area that's about the size of a dime or so that we can actually feel with our fingertips. Whether it's displaced or not is something that we often look for. And then HJR. You don't see this all the time. You might see it referred to, though. This is something called hepatojugular reflex. So we talked about JVD in the last section in the neck. Sometimes if you can't necessarily see the neck veins initially, what you can do is actually push on someone's liver to try to force some of that fluid up and see if it rises. So it's a way to elicit that particular finding. So we basically lay patients down, we press on their liver, see if we can force the neck veins to make it appear and be able to do a measurement that way. So just as a point of teaching, when we do the cardiovascular exam, we focus on particular parts. I don't know if anyone's ever thought about, when you go to the doctor and they listen to your chest, there's actually a very specific placement of where we put our stethoscope in order to listen for certain things. So the first dot right here is if you listen over that right border right next to the sternum, that's typically where you can hear best the sounds of things that are coming from the aortic valve, the pulmonic valve, the tricuspid valve, and then the mitral valve. Unfortunately, in medical school, there's like a very, I didn't like it, but there was a mnemonic that people used to remember this. It was like all physicians take money or something that you to remember, like the APTM, but after some point you don't have to use a mnemonic anymore. Again, so we characterize things based on where their placement on the sternum. We can note whether things like murmurs radiate from one part of the chest to the other. And then we use these different lines to describe things anatomically. But typically this is the placement of a stethoscope when we're doing those parts of the physical exam. And sometimes when you hear a murmur be described, as in here, this would be an abnormal exam, an irregular rhythm with tachycardia, a 3 out of 6 holosystolic murmur noted at the right upper sternal border. So this is someone who heard a murmur when they put their stethoscope here, but not necessarily when they put their stethoscope in the other locations. And then when it comes to murmurs, we typically grade those on a certain scale. And then this is actually what this scale is. So based on how loud it is, and then whether there's something called a thrill associated with it, which is when you put your hand over their chest, you can actually feel the vibration from a murmur. I think actually, do people know what I mean when I say a heart murmur? I know that's like a term that's like out there, and maybe people who haven't actually listened with a stethoscope. A murmur is basically just turbulent blood flow. So it makes, normally you shouldn't really hear blood flow when you listen to the heart, you just hear that lub-dub of the heart. If you hear sounds in between, that's typically what we think of when, that's what we call murmur. There's a variety of different ones that's kind of beyond the scope of what we'll talk about today, but basically it's like a whooshing sound that happens in between that lub-dub that we note, and then the loudness of it is what we characterize when we grade these murmurs.
Is there a relation between having babies a murmur and being born in high altitude places?
Unfortunately, I'm not in pediatrics or cardiology, so I wouldn't know that specifically. There are quite a few, I think, babies that are born, certainly with potentially congenital cardiac issues, where it's so important for us to note those kind of murmurs. I wouldn't doubt that there might be some potential correlation because of the altitude and there being more turbulent blood flow. There's often there's a wide variety of whether a murmur is actually on a normal variation versus not. We often characterize some things as being flow murmurs, which is just they have increased flow, but that's not clinically significant. Sometimes in patients who have severe anemia, so their blood is kind of trying to flow faster or potentially high altitude. But yeah, I don't know about that in particular. I'm sorry. So a normal pulmonary exam, this is what you might see, something that was written in the chart. Breathing comfortably, CTABL. Any ideas what that might mean? I wrote it, it's on the base. It means clear to auscultation bilaterally, so in both lungs. Often the comparison between the two lungs is something that we consider to be extremely important. Egophony is another physical exam finding that we sometimes use to look for areas of the lung that might be consolidated. Wheezing, crackling, rales, those are all different physical exam findings that we note when we listen to the lungs. And then the resonance to percussion. So this is an example of someone doing percussion on the lung. And the really amazing thing about this percussion technique is that if there's someone who has fluid around their lung, we can actually percuss up and down, like almost like you would like a drum, and actually note where the level of the fluid is based on whether it's more tympanic versus more dull. So it's, you know, back in the day when people used to do something called thoracentesis, which is where you can actually pull fluid out from around the lung. Now we use ultrasound to actually localize where the fluid is. But before that technology existed, people actually just did percussion and kind of drew these lines as to where they've noted the change in the resonance, and then did use that as a marker for then to stick a needle in someone, which is pretty crazy to think about. But you know, up until very recently, that's really what people did. It's a really wonderful technique to be able to do that. And again, fun thing to do it at a party, if you go to that sort of party, I guess. So what an abnormal pulmonary exam might look like, you would comment on what someone's breathing status, whether they were labored in their breathing, whether they were using accessory muscles, so whether you kind of see the muscles in their neck puff out because they're really trying hard to breathe, whether they're doing something called tripoding. Has anyone ever heard of tripoding? We often see in kids, basically where they're kind of like out like this and on their hands because they're having so much trouble being able to get air in. We would comment on their breath sounds, whether they were duller in one area or another, whether there was dullness to percussion. So again, this is just visually, when you have consolidated lung, this is what would cause that dullness. When you percuss or when you listen, air won't flow through here, and so you won't hear normal breath sounds. You'll hear, it'll just sound quiet when you have someone take a deep breath in and out. That's why we ask people to do that, because we want to hear those normal breath sounds. If they're taking deep breaths and our stethoscope is over this area and we're not hearing anything, that's usually a concern that there's potentially fluid or potentially like consolidated lung, maybe from a pneumonia or something of that sort that would be causing that, and we would use other techniques to determine what it was that was causing that consolidation. So an abdominal exam. Anyone want to take any stabs at this? Oh yeah, sorry. So great question. So when we talk about fluid in the lung, it's kind of a different thing. There could be fluid within the lung parenchyma itself, but most of the time the fluid ends up being around the lung. There could be like liters of fluid, so 2, maybe 3. There's quite a bit that can build up there. The rate at which that fluid builds up tends to impact the amount of symptoms that they have. So fluid that builds up very quickly tends to cause more symptoms as opposed to someone who's had fluid build up slowly over long periods of time. When we drain fluid, we typically try to only take 1.5 to 2 liters out at a time, because there's a concern for something called re-expansion pulmonary edema, where if you take out too much fluid and then the lung pops back too quickly, that people can then develop complications as a cause of that. And so even though there's more fluid left in there, we'll typically only take out a certain amount at any given time. We'll probably come back the next day and try to take out more, or try to do it very slowly. But yeah, there could be up to a few liters of fluid around the lung. As opposed to the abdomen, does anyone do research in liver disease? So, patients who have ascites or who have fluid within the abdomen that builds up as a consequence of liver failure I've taken out, I think at one point, 12 liters of fluid from someone's belly in one shot. And I've heard of people who've taken out more. There's an incredible amount of fluid that you can hold within your abdomen. And as you can imagine, it's incredibly uncomfortable for a patient to walk around with that much fluid in their abdomen. So fortunately, most people can't hold that much around the lung, but the abdomen is another story. Any questions about pulmonary before I? So abdomen, the BS portion, bowel sounds, as for positive or negative, the presence or absence. We also can characterize the nature of the bowel sounds, so whether they are kind of tinkling. Anyone know what we think of when we think of kind of these like tinkling, high-pitched bowel sounds? It's like very classic for a certain type of condition. Yeah, perfect. So bowel obstruction is typically what we think of. So we comment on whether an abdomen is soft versus hard. Typically soft is obviously normal. NT or ND? Non-tender, non-distended, wonderful. We sometimes will comment on someone's weight, whether they're obese versus not, whether there's any rebound or guarding tenderness. So rebound tenderness is a really concerning sign for someone having called peritonitis or having inflammation of the peritoneum. And what we do is we'll tell patients we're going to press down and then we let up very quickly. And if they have more pain when we let go suddenly, that's really concerned for something called rebound tenderness, which again is very concerning for peritonitis. Usually a very concerning sign, probably seen more often within the surgical sphere of things, but certainly we see it on the internal medicine side too. Guarding is this thing where when you press on someone's abdomen, if they tense up their muscles because they're trying to protect their internal organs, they have, maybe pancreatitis or something of that sort, they're trying to protect their body, so they'll tense up as opposed to just like letting you press on it. That's what we call guarding. And then HSM, hepatosplenomegaly, perfect. So enlargement of the liver or the spleen. So again, that's the translation of it. This would be an abnormal abdominal exam. Someone who had absent bowel sounds, who had a distended abdomen, that was tympanic to percussion. So this would be when you percuss, sounds like a drum, as opposed to sounding more solid, which you would expect, given all the organs that are in there. Diffuse tenderness to palpation, which means that when you press, someone says there's pain everywhere, but this person doesn't have those rebound or guarding. We often see patients, again, with a variety of different manifestations of abdominal pain that can manifest in different ways. And by doing these different techniques, we're able to elicit where this pain might be coming from, what might be causing it. So on the extremity exam, we'll often comment on CCE, which stands for cyanosis, which is this first picture, so this bluish discoloration, often of the most distal parts of the body, so the fingers and the toes is where you see it most often. Clubbing, so this is an example of what clubbing is, and it's basically a change in the angle of your nail. If you take a look at your nail, you can see there's a certain kind of indentation, and the classic thing that we have people do is you put your nails together like this, and you should see a little diamond in between there, like a very, very tiny diamond, a little sliver. Patients who have clubbing tend to lose that diamond because they have an increase of deposition of tissue underneath the fingernails, so they don't have that diamond shape when they put their fingers together. That can be seen in things like chronic lung disease, patients with COPD, or patients who have underlying lung malignancies as well. And then this is lower extremity edema or swelling. So some of our folks who work in cardiology might be very familiar with this. Our heart failure patients are unfortunately affected by this a lot. As you can see, this patient, like how we typically check for swelling is we basically just grab onto a person's leg or press, and you can unfortunately see this indentation that forms after you press, which indicates that there's a lot of extra fluid on there. Most of the times, swelling is caused by fluid, but every once in a while you can see edema or swelling as a cause of something else. But often this is what's commented on in an extremity exam. So a neurologic exam, you could give an entire 2-hour lecture about the neurologic exam because it's very long and very intense. But for the purposes of most generalists, this is what we would use as part of our neurologic exam. Again, it's very challenging to know, to decode some of this. But CN stands for the cranial nerves. There are 12 of them. We typically don't measure the first one. The first cranial nerve measures your sense of smell, but we often don't check for that in the hospital. We just assume that it's normal unless someone says otherwise. But we do measure the other 11 of them, which are mostly all in the face and the upper shoulders. We then look at strength of their upper and lower extremities, and this is typically done by applying resistance. And you can see here, this is actually how we grade strength on a physical exam. So from no contraction at all, someone who's completely unable to move any of their muscles, all the way up to someone who's able to actively move and against resistance. So often what I'll do is I'll have patients fight against me and I'll have them test their strength. If they break that, if they're not able to resist me, that puts them on one of these spectrums, and I'll have to do a little more finer physical exam to really elicit what grading of strength that they have. We also, as part of the neurologic exam, will test things like light touch and vibration. So we'll use things like Q-tips. We'll sometimes cut a Q-tip. We'll break it in half. We'll use the soft portion to look at light touch, and then we'll use the splintered end, which really seems cruel, honestly, when you think about it. We use the splintered end and poke people to see if they can discern more of a sharp sensation. We use our tuning forks to check for vibration sense. We then look at reflexes. This is how we grade reflexes, whether they're absent or whether they're more hyperactive. Most people who have normal reflexes end up being at about a 2, but that's something that is graded. And again, we always check one thing we check things and compare sides, because someone might just have bad reflexes. Some of you may have been told that you just don't have good reflexes, but as long as they're the same on both sides and there's not anything else more concerning going on, that's usually a variant of normal. Questions about the neurologic exam? So the skin exam, this is, again, you could do an entire lecture about the skin exam and how it's described. So there's a really beautiful language that most of our dermatologists use to describe skin findings. They have an incredible vocabulary that's all their own that they use to describe lesions. And you might hear things like, you'll hear about the color of it, where it's erythematous or red, or whether it's purple. You'll hear about the nature of rashes, whether it's something called maculopapular, whether it's confluent, whether it's there's all of these words that are really specific to the dermatologic world and that they use. And so part of it is decoding all the stuff that they use in their language, but for everyone else, we use a much simpler version to characterize different lesions. Just for fun, I decided to include a couple pictures of conditions that we see going from kind of rare to more common. Does anyone know or have any idea what this might be? It's like total shot in the dark, so without no context. Perfect. It's a beautiful description. It's a very diffuse maculopapular rash. It's erythematous. This is actually something called dress syndrome, which is usually a reaction to a medication. Typically, they're usually to anti-seizure medications most commonly. It causes this terrible, terrible rash. People often get liver damage and potentially liver failure as part of it. And often their eosinophils will be very high. So it's this whole syndrome that's really severe. It's actually a dermatologic emergency. There's only a couple things that are considered dermatologic emergencies. Like the skin is not thought of as being this particular organ that causes emergencies, but dress syndrome is actually one of them because there's quite a bit of mortality associated with it. This is actually a condition that we see pretty much every time that I'm in the hospital. I see someone like this. Does anyone know what this is? Cellulitis. So this is a skin and soft tissue infection. It's very, very common. We see this both a lot in the outpatient setting as well as the inpatient setting. can oftentimes be associated with a skin break. When someone has especially cellulitis or infection like this on their leg, what I'll typically do as part of my physical exam is I'll look in between their toes to look for fissures or areas where there might be broken skin. That could have been an area where bacteria gets introduced and then spreads up through the leg. You'll often see this line that we as providers will draw to track where it was when we first saw them, and then to make sure that when we give antibiotic therapy that the redness recedes from that line. So that's why that's why there's that line there. It's really important for us to make sure that what we're doing in terms of antibiotics is actually working, and because there are different providers that see people at different points in time, the line is helpful so that anyone looking at it at any point in time can say, oh, the redness has receded from where this original line was drawn, which ideally means that things are improving. If it doesn't, things are getting worse. We need to change what we're doing. Anyone have any idea what this is? Melanoma, yeah. So I see skin cancer, most concerning type of skin cancer. You can see, some of the characteristics of melanoma is just, severe discoloration. It has these very indistinct borders. This would obviously be of a lot of concern. So a very wide spectrum of what you can note on the skin exam, and all of these would be examples of things that would be included on there. What you would see on a normal skin exam would be a description of something of the warmth of the skin, whether it's warm versus cool. That tells us a lot about someone's circulation, and then whether there are rashes or lesions there. So this is a little more getting into some specialized exam. These are not, so everything we've talked about so far are things that people would typically do on a standard physical exam. When you get into the genitourinary or pelvic exam, that's when you get a little more specialized. These aren't done as commonly unless you are coming in for like an annual exam, or unless you're a urologist or an OBGYN, where you would be doing these exams more standard. But on a genitourinary exam, for males, you would have things like rashes. You would comment on whether there's any discharge, hernias, lymphadenopathy, comment on testicular size and shape. In females, again, similar things, rashes, vaginal discharge. You would do a cervical exam potentially, or what's called a bimanual exam, which is where you could actually try to palpate the ovaries and the uterus on physical exam. And these are much more specialized. I didn't include pictures of this for obvious reasons, but if anyone has particular questions, I'm happy to answer about that. Rectal exam, again, commonly an exam, not one that we do all that often, but can actually have a lot of clinical significance. Anyone have an idea what BRBPR means? Actually, it means bright red blood per rectum. So this is someone who would be concerned maybe was having a bleed within their GI tract. Melena is the kind of sister to bright red blood, which is actually where there's black stool and blood that comes out, which suggests that a bleed is actually coming from higher up in the GI tract as opposed to lower down, which is where you would see bright red blood. You would comment on masses that you would fill on a rectal exam. If you're a man, prostate size, whether there's any tenderness or shape. So our urologists will often do rectal exams to try to examine the prostate, and can actually comment a lot on the nature of the prostate just on their rectal exam. I've actually even heard of, there used to be this clinician when I was in residency who was apparently like world famous, and he actually diagnosed a woman as having ovarian cancer just by doing a rectal exam, because when he did the rectal exam, he was actually able to palpate that there was an additional mass there that was concerning, that then led to an workup that then found someone had ovarian cancer, all from a rectal exam. There was apparently also a myth that he did this exam without gloves, but I won't comment on that. It's really weird. So the lymph node exam, this is an exam that really is a challenging one for a lot of providers because of how difficult it is to feel lumps and bumps. So this is an exam you can actually do on yourself. So there's actually quite a few lymph nodes that are in your neck. So if you actually start from behind your ears, that's typically where we start looking for lymph nodes. Use these two fingers and kind of work your way down, circular motions to feel. You feel under your jaw here. This is typically where we go. And then all down your trachea. And then we typically go up into the area above your clavicle as well, all the way out. That's typically kind of a neck cervical or a neck lymph node exam that we do. So hopefully most of you, or all of you, didn't feel anything. That would be the goal. But oftentimes this is what we do to look for if people come in with concerns for infection within the upper neck or concerns for cancer, unfortunately. A lot of our lymphoma patients actually present with large lymph nodes. And actually the nature of the lymph node tells you a lot about whether it's more concerning for an infection versus a malignancy. So when we do a lymph node exam and we actually feel a lymph node, what we're feeling for is it a tender node? Is it not? What is the shape of it? Is it fixed or is it mobile? These are all characteristics of lymph nodes that we look for. So it's not just the presence or absence. There's a lot more to it than just that. Other places where you can look for lymph nodes would be the axilla, so in the armpits. Like we said, above the clavicle, as well as the inguinal region, so in the groin. Those are typically where most of your lymph nodes are located and where we would do those parts of the exam. These are just some examples. So in this picture, this is someone who has a very large lymph node kind of in that, in the neck area. And then this one's a little harder to see, but you can kind of see this discoloration here. This is someone who has a large lymph node in their armpit area, certainly concerning for anyone who's working on oncology, who works with breast cancer patients. Lymph nodes in the armpit is what we worry about as, for our women who have breast cancer or men who have breast cancer. We worry about there being a lymph node spread into the armpit. So doing a lymph node exam in the armpit is a very important piece of their physical exam. So again, a little even more specialized exams, depending on your clinical scenario, would be things like the knee exam, the shoulder exam. These aren't really done standard unless people have actual complaints about them. The fundoscopic exam, so this is when you look in the eye. This is an exam that you can also do outside of the ophthalmology setting if you have particular concerns about things that are going on in the brain, if there's swelling in the brain. There's a lot of manifestations of systemic disease that can show up in the eyes. Cerebellar exam, this is another specialized part of the neurologic exam, looking specifically at the cerebellum. This has to do with things like coordination. So when we do cerebellar exams, we have patients do things like make this movement, and we have them do a heel to shin test to see whether they have that coordination in them, and they don't. That's certainly a concerning sign something's going on in the cerebellum. Ultrasound is actually becoming a much more common part of the physical exam. With the advent of bedside ultrasound or pocket ultrasounds, providers are actually able to themselves perform exams. So this would not be from an ultrasound technician, but this would actually be a provider who could go to the bedside with an ultrasound and actually look at things like veins in the neck or in the abdomen. They can look at, can quickly look at different organs to tell if something is particularly wrong. So there's this big push to try to teach ultrasound as one arm of the physical exam. Certainly there's only a limited amount that you can see, but actually can give you quite a bit of information, which is why I included it as one of these specialized exams. So a couple resources that I think are very helpful if you have questions about the exam. Certainly there's only an amount that we can cover here today. So the Stanford 25 website actually has a number of videos that go into a lot more depth about how these physical exam maneuvers are done, as well as what they might mean. There's also a lot of really interesting pictures. There's a Stanford 25 blog as well that goes through really unusual physical exam findings that we have of patients who we've seen here at Stanford and what diseases those represent. There's a site called Lexicon. This is a really helpful site just for any sort of medical abbreviation or terminology. If you're doing a lot of chart review and just have no idea what some of the abbreviations are, things are referring to, this is a great place where you can just type it in and it'll spit something out as to what that might mean. Whenever you are doing that, you're looking at the term on Google or wherever it is, context is really important. So for example, that NCAT, abbreviation that we had. If you just type in NCAT into Google, it'll probably come up with like very random things. It's like probably like some like stock trait, thing or whatever. And so it's always about context. So if you're putting in something into Google that you're looking at from a medical perspective, I always recommend putting in some modifier that will tell you, NCAT like medical or NCAT head exam or something of that sort to give Google some context to improve your search results. And then I actually really love this site specifically for physical exam. It's a site from UCSD that goes through, again, different parts of the physical exam. Some of the pictures that I took of the anatomy were actually from that site. And it's really great to show you comparison of like what you see on the outside and then what you're actually looking for more from an anatomical perspective and why we do certain pieces of the exam. So I really love that website as well if you have particular questions about the exam. So any questions? So my dog, I have a lot of affinity for dressing them up in weird and funny costumes. So yeah. At some point in time, my daughter will also be involved in these very extensive photo shoots. But for now, she wouldn't stand for it. Yeah.
I'm just kind of curious how, like, what the interplay is between like the physical exam being performed and the patient reacting to it. Like, how much patient involvement do you optimally want in order to get like a full look at what's going on?
That's a really great question. So I would say that there's a really wide spectrum of what that looks like. So you can do an exam on someone who's not participating, like who's comatose, and we often do that like in the ICU. There's still things that you can examine. For parts of the exam, obviously there is participation that's required. So obviously for the neurologic exam, you're having someone make movements and have to follow commands. And so there is you want buy-in. Like if a patient tells me like I don't want to be examined today, which sometimes happens in the hospital, they're tired, they're not feeling well, I don't touch them. I'm not going to force myself on them to do an exam. But there's still a lot of information that you can gain, even from someone who's not actively participating in an exam, and that's often what I see in the hospital. I sometimes will see patients who are demented, older patients who aren't able to cooperate with every part of the exam, but I can still do a heart exam. I can listen fairly well on lungs. I can stick my stethoscope over their abdomen and kind of press and distract them. But I'm not going to get any meaningful neurologic exam. Oftentimes when we do neurologic exams and sometimes in these kind of people, we just like comment on whether they're moving their extremities. Like they're moving all 4 extremities, they're good. We're not going to be able to get any sort of really accurate strength examination. So you document what you're able to do in the physical exam and note when there might be limitations based on the patient's ability to cooperate. Does that answer your question? Yeah.
And I am a pediatric nurse in the pediatric world, right? We wouldn't say they're 5 months old. We wouldn't say they're ready to transport, right? So it depends on how, if they are demented or not, if they're below an age where they can't communicate. But normal behavior depending on the age of the patient is going to obviously give you a lot of information too.
Absolutely.
Baby is laying there, not moving extremities, their eyes aren't open. Either something's wrong neurologically or they're sleeping. So you just have to determine, well, if my take on it is never wake a sleeping baby, but if you think that something's going on and something's changed, if they were awake an hour ago and they're sleeping now, then fine. But there are certain things, obviously age dependent, and if you're worried about something like a brain bleed or encephalopathy or something like that, that's when neurologically you need to be more concerned about things. But for pediatrics, we get what we can get from babies and young children.
Yeah. It is really tough though when you see a wide variety of people who are just like ill, and especially within the hospital. If any of you have been hospitalized or have taken care of hospitalized patients, they often get multiple exams throughout the day by a lot of different people. So even beyond just from a cooperation standpoint, just from an emotional standpoint, that can be really challenging for a lot of people to tolerate that many exams. And so we do the best that we can to try to, do an exam with more people in the room so that they can just do it in one shot. But certainly because we are a teaching hospital, there's somewhat of a repetition that happens just naturally as part of the process, but unfortunately does occasionally lead to some disgruntled patients, which we try to avoid, but it does happen. Any other questions? Does anyone, oh yeah.
Does it matter what time of day you do the physical exam, or you said it's happening
That's a great question. So I would say that the majority of the physical exams we do on hospitalized patients happen in the morning. So there's certainly things, especially relating to their mental status. So if you can imagine, like, someone woke you up at 5 o'clock in the morning and was like, I'd like to, like, find out your orientation. Like, you may not be completely there. And, you know, we try to give people the benefit of the doubt. And, you know, there's certainly been times when I woke up, I have no idea where I am. And if someone asks me, I'm like, I don't know. You know, we have to take that in the context of what's normal and abnormal. So I would say most of the exams in the hospital are done earlier in the day. But certainly there are, you know, consultants or other people who come in later. As new symptoms come up, they might do an exam to address that particular symptom, and whenever that does arise, whether it's in the middle of the day or the middle of the night. There are certainly certain physical exam. I wouldn't necessarily say that physical exam would vary a lot between times of day, but you know, if someone as a symptom noticed that they had more abdominal pain after they ate, that would certainly, in my mind, suggest a couple of diagnoses that I would be more concerned about. And I might try to see if I could do an exam right after they eat to see if there's something that I could pick up on that I wasn't picking up on before. So it's within context. Does anyone have any physical exam maneuvers they'd like me to try on them? Anyone concerned about anything?
I was just going to make a comment about that. For elderly patients who are demented or have Alzheimer's, if you do an assessment at the end of the day, if there's sundowning, which is when if they're demented or have Alzheimer's, then it's called sundowning, and they get very confused, and so that might be different if it's done at the beginning of the day or the end of the day. And if you're in the ICU, you know, for both adults and pediatrics, for ICU patients, usually, you know, physical exams or assessments, especially by the nurses, are done every 2 hours to 4 hours sometimes.
Yeah.
Now, if they're not in the ICU, physical assessments can be done once a day or twice a day, either by the provider or maybe by, you know, the nurse every 4 hours. The physical exams from nurses' perspective to providers are a little bit different, but still, if a nurse is with that patient for 12 hours and they notice that, you know, their extremities are different color towards the end of the day, then that's obviously something that needs to be brought to the attention of the provider. But yeah, like Poonam said, I mean, the beginning of the day is most when rounds are going on, and specifically for, we're talking about a lot of hospital, but for outpatient, right, they get them done
all times of the day.
But yeah, for the ICU, you know, physical exams are done very, very, very frequently, and you know, for sleeping patients, that can be really challenging, and you know, you have to be very gentle not to wake them up, and maybe you don't do. I mean, if I went into a pediatric, you know, setting and was doing a neuro exam and they're sleeping, I wouldn't open their pupils to, you know, check their pupil reactivity. Sometimes it's necessary, but you know, you don't want to wake people up every 2 hours because then nobody gets better, and you just have crying children.
It's terrible. The hospital is no place to get better.
No,
It's terrible.
No rest.
Yeah.
Just to add your comments in the outpatient setting, there are a couple of things that I think should be taken into consideration. One is the cultural heritage of that person. We see diversity in the Bay Area, and sometimes people feel that it's disrespectful to complain about something to a provider, or they almost perceive that, oh, you failed in giving me comfort. I'm not saying that I'm in pain. If it's a low grade, obviously, if you're in pain, you can help. But so it's important to tease that out, especially in an outpatient setting when you have so many things competing with you. In a hospital, being born is a good sign, right? That is you're going to be out soon. In the outside, in the clinics, there is a to-do, there is the traffic that they're trying to beat. So they try to deceive a little bit things that they would want come to you because they want to be out up there, they want to, you know, it's 2:30, my commute is terrible.
Yeah.
Right? So it's important to know how to tease that out of them when they are kind of not giving you the information because they perceive it as a problem. We work in clinical trials. I have people feeling awful, saying, I'm great, because they're worried to be kicked out of a clinical trial because they perceive it as their life link, right? So it's but we just have
The intuition.
that,
Yeah, this doesn't,
led
yeah.
to adverse events, right?
Yeah. Absolutely. That's such an excellent point. It is really challenging sometimes, and even from a cultural standpoint, and especially from the outpatient setting, about whether you actually have a patient remove all their clothing versus not. There's also this like big thing about doing physical exams over clothing and not being able to really get an accurate assessment of what's happening with someone. A lot of patients might see this as an inconvenience of they have to go in, they have to take off their clothes and put on a gown. They're like, oh, I'm busy, I really want to get out of here, I don't want to have to do all this, or I'm limited in my ability to move around, so removing my clothes is a challenge. And I think for us as providers, it's how do we overcome that and make sure that we're doing right by our patients and doing a appropriate and thorough assessment as much as is necessary and needed. So that's certainly something I don't see a lot in the hospital, fortunately, because most of my patients are wearing gowns. But I remember when I was in residency and asking my patients to remove their clothing was often a really big struggle. But I found that it was very hard to do a good physical exam with someone who's wearing clothes. Oh gosh. Yeah. Absolutely. Unless you actually look. Oh yeah. Absolutely. There's all kinds of stories like this about like near misses, patients who will complain of chest pain, and they actually go into the cath lab and get catheterized, and when they take off their clothes there, they see that they have shingles, and that was the cause of their chest pain, but nobody bothered to actually look at their chest to see that they had this horrible, rash that was consistent with shingles. They send them to the cath lab instead. And so, these sorts of things, like, fortunately don't happen that often, but do happen enough that it tells us that the physical exam still retains some importance as a part of the clinical encounter. And certainly, with your patient, you never know that they have horrible swelling in their ankles unless you actually took a look. You just take their word for it. And some patients may not recognize what's normal and abnormal. What's normal for them, something they've been living with for a long time, may actually be very abnormal and clinically relevant to us when we see it. And so, certainly we want to hear what our patients have to say, but at the end of the day, if we don't look, then we'll never know.
Yesterday something happened in our clinic that I think is a good example in development. We had a service to teach how to correctly measure hurt, because we had a lot of studies that are conducted in origin and visceral fat,
Mm-hmm.
those different than others. So how we were having lots of different measurements. Someone would use the belly button, somebody,
Mm-hmm.
So there was this research, where is the ideal way to do it? Start checking the iliac crest and the limbeo. At least that was the one that we were going to go for. And I realized that all our practitioners, the front desk, the maids who do that, were so embarrassed to touch even each other to find the iliac crest. So sometimes it's also on us. And I know now that I have to do a different service. It's like you come professionally. If you already come tentative, the other person will perceive it.
Mm-hmm.
It creates that awkward moment, and you do not do the measurement correctly.
Mm-hmm.
So it's a lot on us too, that if we are in charge of performing a task, we have to, one, know how to do it well, but second, be confident and not
Mm-hmm.
feel that, I'm touching there,
Mm-hmm.
close to the belly button, so awkward. We cannot be like that, even though it's human nature, right?
Of course.
There are moments that we do feel like that, but that was such an eye-opener that I realized it's not because they don't know how to measure, it's because they're feeling shy.
Mm-hmm.
Talk to the patients.
That's such a wonderful anecdote that I think captures a few things. One is standardization of parts of the physical exam, right? Just because you document it doesn't necessarily mean that one exam by one person is equal to this other exam by another person. And we, when we train providers to do physical exam, we try to come up with like a very standardized way. Like I showed you that picture of the heart with where you put your stethoscope. Those are standard places so that people aren't sticking their stethoscope all around and commenting. There's, specific locations where we do it. And again, for this, where you measure could certainly change your results a lot and have a lot of clinical significance. And then, yeah, you're absolutely right. I mean, it is human nature to think about like invading someone's space and being like, here, I'm going to touch your entire body. It's very weird, right? It's not something that we are used to or certainly comfortable with. It takes time to develop that, but I think understanding that all of you certainly have a higher purpose for wanting to do it, wanting to care for your patient, wanting to make sure that you're getting accurate results is certainly, hopefully should give you some motivation to do that. But certainly the awkwardness piece of it is something that takes a lot of time and certainly doesn't ever like go away. And I certainly always recognize and appreciate what a privilege it is for patients to allow us to do the physical exam on them. If you think about it, they're opening up their personal space to someone else to allow them to do a physical exam. So it's certainly, I consider it, a privilege and try to treat it that way with every encounter that I have and try to treat patients with the respect that I think that they deserve in that particular moment.
Well, communication is so important too with patients. Just saying, just like she said, coming up to someone and putting your hands on their neck without any warning is violating.
Yes.
I was a mock patient just recently for a study, and I was getting an echo done, and without any warning, the cardiologist put the probe right on my neck. And it, one, scared me, and it was awkward. I hate things that are tight or anything around my neck, so when she did that, I was like, whoa. And I just said, you should warn people about what you're about to do, whether I'm going to touch your chest, I'm going to touch your face. And if you're doing any of that, just a warning or some kind of communication with every participant or every patient is just important.
So true.
Thinking that you have the right to do this because you're trained or provider or whatever.
Yeah.
So communication is always good.
Mm-hmm.
Those type of things makes the person feel respected. You're not a machine. You're not
Oh yeah.
a robot. Look in the eye and ask them a question.
Mm-hmm. Mm-hmm.
And instead of like pushing them out.
Right.
So and that communication is vital.
Absolutely. Absolutely. Asking permission to sort of enter that space and to do those things. I would add an additional layer, too, of, I think someone mentioned the diversity that we have here at Stanford, patients who don't speak English, and how important it is that if you are doing a physical exam on someone who doesn't speak English, to have a translator, even more so, even more important in those particular situations where someone is already feeling uncomfortable because they don't necessarily understand the language. So having, an advocate or someone there who can translate for you as you do parts of the physical exam is vital, I would say, because those are patients who feel particularly vulnerable at that point in time. Well, oh yeah. Mm-hmm.
And I've gone into exams and I've walked, like, you gave the shingles example, I walked out and my coordinator was like, well, she said her rash just disappeared. That was good to know. Like, so it's like they'll say things to, you walk in and I had a patient that was like, you could tell something was wrong, and then afterwards the coordinator's like, oh, I heard this thing was passed. So I think like if you hear things as a coordinator, have the confidence to pass that on, and it is important.
Mm-hmm. Absolutely. I mean, I think all of you should feel empowered. Like I said, anyone can do a physical exam. There's not, even if it's just looking at something, physically looking for swelling or a rash or something of that sort, you can always look at it and, bring it to someone's attention. And I would certainly hope to empower all of you to do that. The physical exam is not something that you should feel like is beyond the grasp of what you can incorporate into your practice if you are seeing patients on occasion. I would definitely empower you to do that. Wonderful. Well, I'll stick around for a few more minutes if anyone has any additional questions, but I really thank you for your time and for your wonderful questions.
please sign in, and I'll send out the evaluation for this.